Shall we start the webinar? There's two guests today, and probably I would like to have some opening remarks from Professor Yoko Kato to start with.
Okay, thanks. Yes, yes. So, Toshiki Endo is one of my proud professor, graduate Tokyo University, and he's, of course, one of the top spinal, maybe the tumor, the neurosurgeon, I think, not a degenerative disease, maybe, I think. So, as ACNS, we are very honored to organize such a wonderful the committee led by Toshiki Endo. So I think today is just first the webinar. I think that we could have a good two speakers. So maybe we can learn a lot from both of you. Thanks so much. This is also.
Thank you very much. So, Professor Bolker, I would like to chair of the first speaker, and you probably take chair of the Professor Óscar Alves, okay?
That's good. Thank you. Yeah.
Shall we start from the talk of Salim? Is it okay? Okay. We'd like to hear the lecture from Professor Salim Şentürk, different indications for endoscopic spine surgeries. Please share the slides and please start.
Thank you. Is it okay? Can you see my screen?
Yes.
Yes, but still not in the slideshow. Okay, yes.
Okay.
I think, yeah, we can see it very well. Thank you.
Thank you so much. It's the first webinar. I'm happy to join this great pathology section. Thank you for everything. Thank you, ACNS. My topic is different indications for endoscopic spine surgery. It's an interesting topic, I think. I use mostly monoportal endoscopic systems. There are a lot of endoscopic company, the endoscopic systems, inner size, outer size, different endoscopic systems. Here is the simples. And here is the nomenclature of endoscopic spine surgery, but this is about the degenerative disc disease. But we need to change this nomenclature for whole type spinal pathologies. We need to change, I think. We need a new one. Everybody knows these are advantages of endoscopic spine surgery. We know it, less soft tissue injury, less bone injury, less muscle injury, and less painkiller, and early return to daily life activity, early return to job, early mobilization, early discharge. These are advantages of minimal invasive endoscopic spine, advantage of endoscopic spine surgeries. And these are disadvantages of these surgeries. This is long educational period and excessive radiation exposure. This second one is important problem for surgeons, for nurses, for all staffs, and for patients. And everybody study on these problems. We use some kind of navigation system for decrease the radiation exposure. Sometimes we use ultrasonography, and there are a lot of companies study on this topic for decrease the radiation exposure. This is about disc pathologies. There are a lot of articles in literature describe this the location of the disc disease and which technique is suitable for remove the disc for solve the disc pathologies. There are a lot of articles about this. This is about the disc. There are algorithms about this. Which technique is suitable? This is easy. This is the interlaminar. This is transforaminal approach. But all these about the disc pathologies and spinal stenosis. And these days, we can operate all type disc pathologies, cervical, thoracic, lumbar. We can operate all type spinal stenosis endoscopically. But this indication is not about just degenerative disc disease. And we can operate infection, we can operate odontoid fracture or congenital anomalies, we can operate vertebral fracture, we can operate all types of spinal pathologies mostly, and spinal metastasis, tumor lesions, and intradural lesions. This list is growing day by day. This is the simples. Here is the article published, the new one, about the spondylodiscitis. And the conclusion of this article, these data suggests that percutaneous endoscopic debridement and drainage may be considered as a first-line intervention for spondylodiscitis. This is the result of these articles. If you use endoscope, like it's the same disc surgeries. You can use interlaminar rod, you can use transforaminal rod, you can remove the biopsy from the infection materials for culture. After you can wash all disc necrotic disc tissues, you can put some kind of drainage, like open surgeries, and you can operate. The results section is most important. This is a new article, new one. Another repair of the pars defects. This is a, and here is the article. This is a new 15 years ago published. There are a lot of articles about this topic. You can operate if you have a young child, if you have a child patients with pars fracture, with severe back pain, you can operate these patients without severe surgeries. Like just endoscopic view, you can see the defect size, and you can see the cranial and caudal part of the defects. You can remove the fibrotic tissue between the bones with endoscope. After, you can put the percutant screws. After, you can put the bones, this empty area, and you can get a strong vertebra. This is a step of these surgeries. Another one, facet cyst. This is like the compression surgeries. 2 days ago, I operated one patient. If you have a facet cyst, you can operate this cyst transforaminal rod, interlaminar rod. Where do you see the compression? You can use the technique transforaminal or interlaminar. If you have a cyst, the inner side inside the central canal, you can use the interlaminar rod. If you have a cyst pushing the exiting nerve root, you can use the transforaminal rod. The main problem of this surgery is a tissue disruption. Why? If you open the ligamentum phloem, you may see you cannot see the clearly border of the cyst. You need to see the cranial part of the cyst. You need to see the caudal part of the cyst. You need to describe the main dura. You need to see the traversing nerve root. After, you can remove the cyst. If you lost your position, you cannot do surgery. If you are confused which tissue, if your description is not okay, you cannot finish the surgery. If you lost, you need to find the pedicles, you need to find the exiting, traversing nerve root. After, you can go back, you can remove all tissue. It's a safe, effective surgery, but you need to follow some rules for perform the surgeries. Another one, spondylolisthesis. If you have there is two alternative methods. If you have a back pain related to spondylolisthesis, you need to do fusion surgeries. You may do fusion surgeries. Here is the 3 technique: full endoscopic technique, biportal endoscopic technique, or endoscope guided technique. If you have a back pain. Sorry, this one. I operate these patients biportal technique. Here is the you need to describe your position here. One side is for optic, the other side is a working channel. Here is our target point. You need to remove this part, facet joint. Here is the parts interarticularis. We may use all microsurgical tools for perform the surgeries. And here is we put the screws. We put the cage between the bones. Here is the exiting nerve root. Here is the main dura. And after that, we put the screws, percutant screws. Here is this cage. Just skin incision this side. We discharge these patients another day. If you have a leg pain because of the compression of the exiting nerve root, and stable vertebra, just radiculopathy, you may operate. You may do decompression is okay, is enough for you. How can you do it? There is the problem here. There is the disc tissue. Here is the corner of the inferior vertebra, end plate. This tissue is pushing the exiting nerve root. This is our target. Just leg pain. Just this situation without back pain. This is our target. If we remove these tissues, if we create a new corridor for exiting nerve root, it's okay for us. How can we do it? This is a main problem of this. This is a nerve root damage. If you put the working channel to the here, you can damage the exiting nerve root. If we touch here, superior articular process of the inferior vertebra, if we move the working channel to top of this corner, if we remove these tissues without touching exiting nerve root, we can operate these patients without complications. This is a safe technique. There are a lot of articles about this topic. This is a completion. There are a lot of case series and about this. Another one, Chiari malformation, tethered cone syndrome, just case simples there are in literature. If you are an experienced surgeon, a master endoscopic surgeon, you can operate. But we need a lot of cases about this. Just case simple, this one. Another one, this is a complication of minimal invasive surgery, the cement leakage. We published this one. Here is the video. This is a complication, main complication. This is a minimal invasive surgery, but patients wake up with severe leg pain. You need to operate these patients. You cannot open these patients. If you have an endoscope, you can operate endoscopically. It is a legal solution. It is a small solution for us. And under endoscopic view, you can operate and your eyes into the spinal canal. Here, you can check around. Is there any compression or not? You can remove all tissues. Here is the window, just little one. After you can discharge these patients. You can manage this type of complication with endoscope. Another one is screw malposition. Sometimes we can see this type of complication, and patients wake up severe leg pain, and we checked CT scan, and we can see that this type screw malposition. And if you have this type tools, you can cut one part of the screws. Here is. We distract the nerve tissue to the medials. After we can cut. Here is the top of. Here is the cement leg, and the medial part of the cement leg. There is a screws. You can cut it. You can shave this medial part of the screws. This is options for you, and this is vertebral fracture. And if you have a back pain, just back pain, you can do some vertebroplasty or kyphoplasty. But if you have a leg pain, you need a decompression. If you decompress these tissues, these patients, you need to do fixation. But if you have an endoscope, you can remove these patients just have a leg pain. You can remove the tissues. After endoscopic view, you can put cement and you can create a new vertebra. Here is the bone. Here is the nerve tissue, cranial caudal part, bone. This is coming to the spinal canal. Here is the bone. We may shape this bone. Sometimes we use the protecting burr. We create a corridor for traversing nerve and main nerve tissues. After endoscopic view, we can put the cement to the vertebra. All cement part coming our side, but under endoscopic view, you can push to this cement to the top of the vertebra, and you can create a strong vertebra. Here is we are checking around. Here is the bone, strong one. Here is the nerve tissue, catheter here. And just one day is okay. Other days we can discharge this patient without any severe instrumentations. This is the alternative. This is the metastasis. This is important, especially metastatic lesions. Because of the severe pain, you need to manage all problems, and the patient's tired, the family tired, and how can you manage it? If you have a tumor on spine, you need to follow the oncology algorithm. You need the biopsy. After that, you can do the surgeries. If you have a primary tumor, you cannot do it. This is just decrease the pain. This is just pain management. How can you operate these patients? Another problem is the vascularization of the metastatic lesions. If you do the surgeries without any embolization of the tumor, you may see the severe bleeding. You cannot finish the surgery mostly. But if you embolize the tumor, you can operate the surgery safely and easily, like this. Here's the tumor. Patients took a lot of painkiller. Here is the, and yes, here is the nerve tissue. Here is the, we can distract. Here is nerve tissue. Here is the tumor. But there is no bleeding because before the surgery, we embolize the tumor. It is important. You can do biopsy. You can remove all the tissues. We know that the diagnosis of the tumor, you can coagulate, you can remove. It is easy for us, like disc surgeries. And after the surgery, just patients use just 1 or 2 painkiller. But before, 6 or 7 types painkiller she take. Another one, intradural lesions. Another one, intradural lesions. This is a case simple. We published 6 years ago, but there are 4 or 5 cases, the same case in the literature. But we can operate this type tumor. But main problem of this type tumors, the CSF pressure, how can you manage it? You need to use the low pressure water, and you need to use the body temperature water. The other step, you need to know where is your location. It is another important problem. After that, like microsurgery, it's the same step. You need to distract the tumor from the nerve tissue. After, you can remove the tumor. Here is the dura. We cannot put the camera inside the spinal canal because of we removed one part of dura here. And here is a dissector. We are dissecting the tumor from the nerve tissue. You can remove the tumor here. It's not easy. It's just case simple. We can check it around. Here is the dura. How can you close the dura? If you cut the dura 1 centimeter, or if you see the damage of the dura more than 1 centimeters, you need to use some match, some stitch for close the dura. We use the dural mesh to closing the technique. After 3 years or 5 years later, here is the MRI. Everything is clear. This is another one, transmass odontotomy. We published this one this year. How can we operate? We cut this part. We used the transmass rod. There was a scribe losing. All systems losing. We removed all systems after we cut the neck of we cut here. Our plan removed all part, but there was a shoulder problem. We didn't move to the camera to the top of the dance, just we cut the neck. After that, we saw the head coming down because of the CSF pressure. We cut it, top of the dance. We changed all screws. Here is we cut all downs, and we changed all systems. And the conclusion, endoscopic spine surgery is becoming increasingly important due to its minimally invasive nature and growing the list of surgical indications. I asked these questions to the ChatGPT. What do you think about endoscopic spine surgery? Answer is, endoscopic spine surgery is a promising and rapidly evolving technique that offers less invasive treatment options with comparable outcomes in selected spinal disorders. This is the answer of the ChatGPT. Thank you so much for invitation me. Thank you so much for getting me.
Thank you, Professor Şentürk, for the great lecture about endoscopic spine surgery with many pathologies, I think. Is anybody have a question or comment about the presentation? Otherwise, I would ask Professor Raja for Professor Boker, please.
Yeah, excellent presentation, Dr. Salim. I agree with there are now a lot of indications of endoscopic spine surgery as the expertise is growing and the learning curve is being taken care of. I think there are now a lot of indications of endoscopic spine surgery, and you have very aptly summarized all of them. I also believe that the fluid-based endoscopy has revolutionized the visualization compared to the previous first generation endoscopy, which was air based. This fluid based is providing better visualization, and that's why the surgeons are increasingly able to do a lot of things with a fluid based, either a monoportal or a biportal endoscopy. Just a comment, yeah.
Sure, thank you.
Yes.
I have a question. Excellent presentation, Salim. Very nice. I have more a kind of technical question for you. We have done as well one case of foraminal neurinoma, I guess some root 4, L4. and doing the bone work was not a problem, opening the dura, etc. But we had a problem. The fact that we work just with one end, it was really hard to apply contra torque in the nerve root to do dissection. And the neuromonitoring was always beeping. And so my question is, for this kind of intradural tumors where you need a second hand, would you see a role for biportal instead of the classical endoscopy?
It is about your experience. If you have experience just monoportal endoscopic systems, and you may do it. If you have experience at biportal endoscopic systems, you may do biportal systems. It depends your education, depends your experience. But biportal is the maybe you can use the both hand. You may think I use both hand, but monoportal I use just one hand, but my fingers just 3 hands. This one is I use 3 hands, like just in one hand.
Thank you.
Thank you.
Any comment, Professor Nagashima?
Hi, and thank you for the excellent lectures. Personally, I never use an endoscope, so I wonder how to run such a great surgery by endoscope. How can I start?
I'm sorry, how can I start? It's a question.
Yeah, because I never do the endoscopic surgery, so I think that I want to start this kind of surgeries, but I never do that. So, it is important for the young surgeons as well. So,
Okay.
please tell me how to start the endoscopic surgeries.
Okay, you need to follow the courses. Courses is important. Cadaver course important. Some simulation course. There are a lot of courses around, and you need to follow the course. After that, you can start with just senior. After you can start alone. You need to, if you follow these rules, you can do the surgery safely. You need to follow this algorithm for perform the surgeries. Courses with senior surgery, with senior, and after alone, not directly alone.
Thank you. So I'm gonna start with the cadaver. Thank you.
Thank you.
Okay. I have a question. How many percent of the operations will be done by the endoscopic versus open? Is it like 100% endoscopic or in your facility or department?
Case by case. Some cases I do microsurgery. Just I not focused endoscopic surgery. It depends the MRI. It depends patient situations. Some situation I do microsurgery, some situation I do endoscopic surgery. There is no rules. It depends your experience.
Okay. Thank you very much.
Thank you.
So I'm gonna pass the mic to Professor Boker.
Yeah, thank you so much, Dr. Endo. We have the next talk by Dr. Óscar Alves. It's my proud privilege to introduce him. He is the head of neurosurgery at the Porto University Hospital in Portugal, and a very fine surgeon, avid researcher, and has been in all the spinal education forums, including the WFN Spine Committee, CSRS, the International Academy of Spine. And it's my honor to invite him for his talk on complication in cervical spine tumor surgery. Over to Dr. Alves.
Thank you, Professor Cato. Thank you, Dr. Boker. It's really a great honor to be first in the committee and then animate this first spinal pathology webinar. So my lecture is on complications or mitigation of complications in cervical spine tumor surgery. I have no relevant disclosures for this presentation. So if you look at the complications, cervical spine tumor surgery is still prone to really major complications. I would say almost 1 in 5 patients will have a major complications. And at the top are the wound problems, almost 10%. Dysphagia is really a common problem. Esophageal injury, vertebral artery injury, recurrent laryngeal nerve injury, thoracic duct injury, diaphragm palsy, CSF leak, and implant failures and pseudoarthrosis. And these are the kind of summary of my mitigation strategies. And the first one that comes on the top, it's really related with the patient frailty. And this is really important if you're dealing with a spine metastasis, and you have to know this NORMS framework, which is based on neurological status, if the patient has a myelopathy or not, the oncology, tumor type and biology, what is the mechanical stability, and this relates to the SINS classification, and most important, the systemic, the extent of disease, the age of the patient. So you have to do a very exhaustive pre-op patient evaluation. And I'm sure you are familiar, although the limitations and the potentially unstable no-go zone, it's really an important classification. So first advice, exhaustive pre-op patient evaluation. And just to illustrate that, I have here two of a kind. Case one, 45 years old female, neck pain, shows a mass in C4, neurological intact. And another case, 85 years old man, pretty much the same pathology, the same symptoms, neck pain, a little bit wider lesion, C345, also neurological intact. So for the first case, perfectly fit patient, and according to the Boriani scale, we did a resection of the chordoma. This was revealed to be a chordoma with a biopsy, and we did the osteotomies to free up the tumor and achieving complete resection, as you see here, first stage posterior to release, and then flip the patient and remove entirely the tumor. And as important as is the deconstruction, working around the tumor, the osteotomies to get in with margin, unblocked with margin resections, is the reconstruction of the spine, as you see here. So, and this is based on this knowledge that surgery aiming anakin appropriate resection is the best method to achieve long-term disease-free survival. If it is not feasible, anakin appropriate resection attempt for unblock or interlesional resection is futile because you have a high probability of recurrence. This is the second case, very similar, 81 years old patient and very frail patient. We, instead of operating or trying to remove it, we did proton therapy alone. 70 grays in 35 fractions, and the patient, you see, remission of the tumor and very residual tumor 1.5 years later. Unfortunately, there was a fracture that we solved with a posterior fusion. But as you see, proton therapy is really another option that you can apply instead of surgery to this kind of patients. And if you look at here, with high dose proton beam radiation, it's a game changer even in this kind of primary tumors with very interesting survival rates. There is a lot of discussion doing pre-op radio or post-op radio. If you do it pre-op, you can have a major problem with wound healing. So the second strategy is know when not to operate the patients. And this lends me to the chemotherapy topic, which is really a game changer.
Sorry, Dr. Óscar, we couldn't see your screw. It's my problem or everybody is the same?
Sorry?
We couldn't see your screw, your screen. Everybody knows or just me?
No, I think Dr. Salim, we can see it and it's moving. Probably it's problem at your end.
Oh, it's mine. Okay, sorry that. Just comment. Okay, thank you. Sorry.
So chemotherapy is a game changing in metastasis. As you see in advanced breast cancer, these kind of new medications, letrozole, there is an improved survival So the advent of new target chemotherapy and immunotherapy drugs is really a game changer. And surgery has no purpose in increasing survival. You see a case here before chemotherapy, after chemotherapy, and a completely osteolytic lesion became in a very nice feature. For example, also for radiodin thyroid cancer, refractory thyroid cancer, multi-target tyrosine kinase inhibitors look at the progression-free disease in months compared with placebo. So this kind of chemotherapy will offer you the possibility to avoid many operations with reasonable results for the patient. And this is the case of a recurrent follicular thyroid carcinoma after surgery and all sorts of treatments. Chemotherapy was really a game changer. Another important topic is it's really important to distinguish between primary tumor and metastasis. And if you look at the incidence, obviously spine metastases are much more incident than primary bone tumors, although metastases are less frequent in the cervical spine if you compare with thoracic spine. The role of biopsy is really important when imaging is not clear-cut. It should be done a close CT-guided biopsy because it's more oncologically sound than open biopsy. It minimizes the risk of complications of normal tissue. And in my opinion, an oncologist spine surgeon should coordinate biopsy. Why? Because you need to ensure that the tract of the biopsy will be included in the surgical specimen. And why is this important? Because there are two contrasting views on the role of surgery. And in order to delineate a proper surgical strategy, with the primary tumors, the objective is to cure or prolong disease-free interval. Surgical resection is generally unblocked with margins. And also the probability of distant metastasis is really low and adjuvant therapy is often limited. Whereas in metastasis, there is a shift in the surgery paradigm, separation rather than cytoreduction to improve neurological function, and surgery comes to biomechanical stabilization for pain control. And this is a very important decision framework, looking at, as I said, at the previous scale, and this will lead you to the concept of separation surgery in case of metastasis or stabilization if the patient is unstable. So better control, local control, regardless of histology and volume. That's what separation surgery followed by stereotactic radiosurgery can offer you. So the new protocols of stereotactic radiosurgery overcome the concept of radio-resistant tumors. And this is basically what this shows. So you have long-term pain improvement, radiological control, clinical improvements. Many papers showing that if you apply this concept of separation surgery followed by SRS, you have very good results. It's really important if you deliver high dose because you have a much better local control of disease. Planning is certainly very important, like in this case here. Another case here of a 45-year-old male, lung cancer, no previous treatment. Ultrasound can be used to assess the restoration of the CSF space, and that will be the end of your separation surgery. And then patient follows the stereotactic radiosurgery and stabilization, and 9 months post-op, a really nice scan. Tumor vascularity is also really important, and we know that there are primary tumors and metastatic tumors that are hypervascularized, and you should be aware of that. And there is a role for preoperative embolization in those cases. Renal cell carcinoma is one of them. Previous surgery, recurrent disease, post-op reduction of tumor vascular supply, as you can see here, and that was achieved made the surgery, the revision surgery, much easier. Also, if you're dealing with hemangioblastomas, intradural tumors, also very important to make your life easier and do some sort of angiography and preoperative embolization if you find a single pedicle as we could find here in this position. Preservation of critical neurostructures, obviously, it's the most important part of it. Like in this case of a cervical ependymoma, very careful dissection, total piece removal of the tumor and reconstruction with laminoplasty, and this is the follow-up, and the patient completely neurologically intact. And obviously, if you have to apply neuromonitoring, the D-wave especially is really important to achieve a good result. This is a kind of malignant schwannoma where you have to do a careful neurodissection, not only from the spinal cord, the nerve roots, but also from the brachial plexus, and also reconstruction at the end of the operation. Recurrent laryngeal nerve relates with dysphagia. It's really an important structure. If you are operating on the right side, the nerve crosses under the subclavian artery, which means that you have much less amplitude of nerve retraction during your tumor surgery. So pay attention to this structure. And this young man with the C2, C3 chordoma, we achieved the complete removal. I'll show the images later. But unfortunately, he developed a severe dysphagia and is for life now on a gastrostomy. Very important here also this dissection. It's a neurinoma of the vagus nerve, from the vagus, from all these important neurovascular structures. Look at the internal carotid artery. The internal jugular vein was completely collapsed, and that was the end of the operation with removal of the surgery. So another really important topic when you're dealing with cervical spine tumors is the control of vertebral artery. Vertebral artery is encased on the lateral wall of the spine, and you should be able to recognize it and to expose it and mobilize it. It will make your life much easier. And is this possible? Yes. Vertebral artery is surrounded by a venous plexus, and both are encased in the superiosteal sheath. So you have to do a careful superiosteal dissection between the bone and the superiosteal sheath, and this will, it's the key element to do a proper dissection of the vertebral artery without major risk of injury. You can have some minor venous bleeding, and this is easily solved with coagulation or tamponade. And the key element is to identify the vertebral artery inside the transverse foramen and open the foramen, skeletonize the vertebral artery above and below the lesion, so you can mobilize medially or laterally the vertebral artery. And these are some case examples of surgeries. Here it was a chondrosarcoma case. This is the lesion. Vertebral artery seems to be completely collapsed, but actually after we freed the tumor and released the vertebral artery was patent, as you can see in the post-op imaging. Sometimes this is not possible, and there are cases like osteocytomas, some metastasis, some aneurysmal cysts where vertebral artery superiosteal dissection may be impossible to accomplish. And in that case, you might want to do balloon test occlusion to look for collateral circulation in the polygon of Willis, and be prepared to sacrifice the vertebral artery. If you look at, for example, in the craniovertebral junction, you have these loops of the vertebral artery. If you mobilize the vertebral artery from C1, you can transpose the vertebral artery, and this will give a very generous pathway to assess the pathology, or mobilize the vertebral artery from the posterior arch of C1 above. This will give you a very nice lateral entrance to the tumors. This is really important in dumbbell neurinomas. There is what I call the incertitude principle. Vertebral artery can be displaced anterior, medially, or posterior, like in this case. So I think, like in the war, you have to see and control the enemy at the first. So you have to know where vertebral artery is. So I always do most of my neurinomas. I use an anterolateral approach, and I control the vertebral artery at the beginning of the operation, so I'm completely free to do a proper dissection and removal of the tumor. Cases here of C4, C5 neurinoma. This is a case of an osteochondroma with mobilization of the vertebral artery. Multiple myeloma here, also with compression, instability. Patient is disease-free. An osteoblastoma, typical tumor of C2, also with mobilization of the vertebral artery. Case of a C4-5 chordoma. CSF leak and wound dehiscence is really a great problem in surgery. And I show you one of our cases that we operated 1 year ago, 81 years old male, neck pain, mild myelopathy, a C2 chondrosarcoma. We could do unblock resection. There was some intradural expression. We closed, watertight the dura, but patient developed a pseudomeningocele, another hydrocephalus that was drained, an acute subdural, and this was the last follow-up. So do what you can to achieve a watertight dural closure, multiple layers of dural graft, sealants, lumbar drainage if you want. So this was really minor technical detail that can ruin your case and your operation. Of course, sometimes you end up with these major defects and you need soft tissue coverage. You need a multidisciplinary team where your plastic surgeon can come in and help you to do this kind of reconstructions. And obviously, like in any spine surgery, it's not only about taking out tumors, it's also about reconstruction of the spine, and you need solid biomechanical principles of stability, of reconstruction above and below the lesion, to levels, especially in tumors, because bone quality is not that good. And surgery comes mainly to control pain and stabilize the spine, and this was a metastasis of C2 that we treated just with stabilization and radiotherapy, and we were still able to insert a screw on C2, and patient was satisfied. Again, another case here, metastasis, and we end up with big hole in the vertebral body. We had a 360 reconstruction to get a good result. An osteolytic, this is from Gokaslan group, an osteolytic lesion of C2, and it's quite interesting to apply these concepts of destruction to have a perfect reduction of kyphosis, as you can see here. And most important of all is to understand load sharing at the craniovertebral junction. The biomechanical forces are transmitted from cranium to condyle, lateral mass, C2 pedicles to anterior column in the subaxial spine. So this kind of lateral reconstructions are really important. And this is our case of chordoma, where we have not done that. We had a vascularized fibular graft here. The patient holds for the moment, but certainly this is a criticism. We should have done 2 pillars on the lateral side to have a nice support. So these are the mitigation strategies. Requirements: you have to have a sound knowledge of spine and paraspinal anatomy, be familiar with different approaches of the spine, comfortable with spinal instrumentation and reconstruction. You have to have the support of oncology team. Strong multidisciplinary work and expertise is really, really important. Meticulous planning, and don't forget to follow very carefully your patients. And this has to be done with a durable patient benefit, with a satisfactory post-op function, and really acceptable at morbidity. Thank you.
Thank you, Dr. Óscar, for an excellent presentation. You have covered everything from extradural tumors to the extramedullary, as well as the neurofibroma and the schwannomas. Any question from the panel or the audience? I do not find any in the chat box. But just to start the discussion, do you what is you have seen a lot many cases. What is your standard now for hemangioma, which is quite common? In hemangioma with an epidural compression, what will be your protocol? You will preoperatively embolize and then do resection and reconstruction, or there are papers in which people have used alcohol injection along with stabilization. So your take on that?
Right. You're talking about virtual body mangiomas,
Yes.
Oscar. I mean, it's really, and most of the patients I really follow them, and I can't remember. I remember very few, really very few that we needed to operate. So my strategy is really to follow up and do it periodic imaging, and in case it becomes aggressive or compression. I think it's with neurology, with spinal cord compression. Obviously, you need to operate them, and you need to work outside the tumor to avoid major bleeding, obviously, and if possible, also try to some sort of embolization, which is not always easy because you don't see most of the time you don't see any pedicle or any. So my advice would be really to work outside the tumor and have a really unmarged unblock resection with huge margins to avoid getting into the tumor. That would be. I have no experience with alcohol injection.
Yeah. So the challenge in these cases with embolization at times is that the feeders are so tiny that
Exactly.
to super selectively cannulate them is very difficult.
There
So
are
most of
reports
the
also on radio frequency, on different kind of minimal invasive strategies, but we don't have this expertise.
Yeah. So at my center, and I may have done some in which we use the absolute alcohol to embolize them intraop rather than pre-op embolization. It's intraoperatively embolization, and then do a short segment fixation so that it doesn't collapse, and it has worked well. Most of the times, the soft tissue resolves on follow-up, and there is a sclerosis of the bone. So it has worked in our hands, but obviously there are difficult tumors. I agree with you. Another question is regarding osteochondromas. Uh, you have shown one of the cases. What do you believe is the role of radiofrequency vis-a-vis surgery? Because many people are just doing radiofrequency for that, and the patient becomes pain-free.
Right. Yeah. I mean, it depends what you want to treat. If you're dealing just with pain, I think radio frequency, if it will be reasonable as a first attempt. Again, you have to follow the patient, and if you see that there is a tumor increase or some change in signal, because sometimes these cases they can turn in malignant tumors. So it's really important to be always following those patients. But as I said, you have to tailor the surgery to the needs of the patient. And I agree, if the patient pain is the main problem, there is no instability, you probably can do just pain treatment with minimal invasive techniques and follow the patient. So I think it's a good option.
Yeah. Thank you so much. Any Dr. Endo, you wish to have some questions?
Yeah, but there's is it Dr. Aniak? You want to make comments because you raised your hand?
Yes, thank you so much, sir. Yeah, thank you, Professor Alves, for this excellent presentation. Yeah, in the anterior access to cervical spine, a sympathetic trunk injury can take place. So, is there any particular precaution you take to prevent sympathetic trunk injury? Thank you
Right.
so much, sir.
Yeah, I mean, sympathetic chain lies anterior to longus collis and longus capitis. And there is always a little fascia, a little aponeurosis surrounding the plexus. So what I would advise you to do is obviously identify it and then cut this aponeurosis along the sympathetic trunk. And then you can mobilize the sympathetic trunk medially or laterally according to your needs. But certainly don't try to isolate the sympathetic trunk. You need to isolate it, but with the aponeurosis. Okay, so the technical tip is to cut the aponeurosis along the sympathetic train and protect it with that and mobilize it. Not try to dissect it or to, that would be my tip to avoid Horner syndrome, which can be very trouble for the patients, obviously.
Thank you so much. Thank you so much, sir. Much appreciated, sir.
May I ask a question about the vertebral artery? You have shown the many cases of the cervical spine metastasis, then I wonder, if there is an involvement of the vertebral artery, would it change the surgical indications or any, surgical strategy? Do you have any, can I have your comment about the vertebral involvement of the cervical spine pathology?
Sure. So, I mean, most of the times, often vertebral artery is just displaced, can have a normal caliber, but it can be on imaging occluded. We know, as I showed you, some cases, dissection around the vertebral artery is really impossible, and we know which cases are those, like osteocytosis, some sort of metastasis. But most of the time where you see a vertebral artery collapse, indeed it is not collapse. So the tricky point is always come above and below the lesion, the pathological area, try to identify the normal caliber of the vertebral artery, and then come to the lesion and always respect this plan between the vertebral artery and the tumor. And most of the cases, you'll be surprised how good dissection you can do. As I said, if you suspect that it's completely occluded, perform a balloon test occlusion, or even if you are not so experienced surgeon and you are starting to work around the vertebral artery, also do a BTO, because this will make you more comfortable. And of course, you can be prepared according to the data of the BTO to sacrifice the vertebral artery if this is the case. Intraoperatively, you can do bypass, it's possible. Most of the time, one vertebral artery is enough to compensate, fortunately. That's the rule. Around 2/3 of patients, there is always one dominant vertebral artery. So my advice is always try to do your surgery on the side of the non-dominant vertebral artery, because if any problem comes, the other one is intact.
Thank you.
Yeah. One important message from Dr. Alves' presentation was to judiciously use the neoadjuvant chemotherapy in some metastasis, which can downstage the tumor before you go for surgery. That point need to be emphasized for all the audience, that at times there are now good drugs for CA breast metastasis, as well as even in primary bone tumors like aneurysmal bone cyst or giant cell tumors. People are now using denosumab with quite effectively to downstage it and to keep it under control. And they are
absolutely. I mean, the drama with these drugs, like, they are incredibly expensive and not worldwide available. We should fight for making them available in a large scale, because they are can be really expensive. But a lot of those patients can be controlled with those drugs even without any surgery. You follow them, obviously, if there is a fracture, if there is a problem you have to solve surgically. But it's amazing. It's really a game changer. There are two things in tumor surgery that are game changers, which are the new chemotherapy drugs and immunotherapy drugs, and the separation surgery for metastasis. I do surgery now for almost 30 years, and I remember my first years as a resident dealing in the OR with metastasis and bleeding everywhere, try to remove everything. I mean, there is no more room for this kind of operations, you know. Just do the separation surgery, stabilize, and send the patients to stereotactic radiosurgery, which also I know that it's not available in all over the world, but we should really fight for that, because cancer patients are a huge number in every country, and then there will be more and more. So we need to fight for these resources.
Yes, I agree. So, Dr. Alves, based on this separation surgery and the neurochemotherapy, what is the current role of en bloc spondylectomy or surgery then?
I mean, if you're dealing with the metastasis where you have a young patient and long-term survival related to the primary disease is good, and you have a single lesion, I think there is still a role to do a spondylectomy in very selective cases of metastasis. Definitely, we should not forget that technique, because you can cure a patient as well in a more definitive way. But I think in my hands or my experience, this is coming less and less, because you have really efficient tools that can help you to avoid the morbidity of major operations.
Completely agree. Yeah. Yeah.
If I may ask one question, Prof, can you hear me?
Yes,
Sure.
yes, Raja. Please go ahead.
Okay. The thing, first of all, let me thank Prof. Óscar Alves for giving such a beautiful lecture. And regarding the intraoperative actions, I just like to make a comment that the use of Doppler is we are heavily dependent on for when we are dissecting close to the vertebral arteries, be it the craniocervical junction or dealing with spinal tumors. And one question I would like to ask is that the use of intraoperative neuromonitoring is indispensable in when you're operating on spinal cord tumors, especially the dumbbell type of tumors that you showed. We have had incidences when we have lost the signals even while positioning the patient. And so I think the use of D-Wave or MEPS is really indispensable. What sort of monitoring do you use in your place?
I mean, certainly we try to do in our intramedullary tumors. For extramedullary intradural, I don't use much neuromonitoring. We don't paralyze the patients during our anesthesia. So you have a good feedback. If you are not being gentle with nerve root, there is some muscle twitching. But for intradural tumors, it's mandatory to do somatosensitive motor potentials, but especially the D-Wave. The problem is with the D-Wave, the devices we have to monitorize, they are not yet really user-friendly, and they are very bulky. Sometimes implies a bigger than need laminectomy, or you just have to slide the implant over the spinal cord, and you don't feel always comfortable with that. And sometimes it doesn't really stick in the spinal cord. So there are, in my opinion, some technical issues that need to be improved. But in case you lose potentials, it's always a hard question what to do. I personally, if I feel that I have not done big errors, not done big damage, I continue the surgery. I mean, there is no way of closing a patient, see if the patient is moving, coming back. If you lose potential, most of the times, if I feel that was not a major iatrogenic maneuver that it was done or produced the loss of potential, I still carry on the operation. I don't know what about you. Do you do the same?
Of course, we do the same. We
Yes.
have to, because we have taken the patient for a surgery.
Yeah.
And
Absolutely.
we should
Absolutely.
go ahead.
Absolutely.
Thank you very much.
Thank you.
Yeah, Dr. Endo, we can conclude with your remarks.
Okay, any more comment? Dr. Nagashima, is it okay? Any comment?
No, it's okay. Thank you.
Okay. Yeah, thank you very much for very informative lectures to speakers. we were able to learn the endoscopic, I would say, minimally invasive technique, and also the current knowledge about how to manage the metastatic spinal tumors. Yeah, thank you very much, and for gathering and the Saturdays. And we would like to look forward to having another event in the near future. Any message, Professor Yoko Kato?
Well, thank you very much for the nice lectures. Just I want to ask finally, Dr. Oscar, excellent talk. Thanks so much. I think still in Japan, the younger generation does not have not so much interest of the spinal lesion, spinal neurosurgery. Of course, Dr. Endo is the top leader of the field, but still many of them have an interest of the open surgery. So how you can teach the younger generation, give them some interest of the spinal lesion or spinal surgery?
Professor Kato, this is a very interesting question. I think we could talk about that more than 1 hour. And we need to change positions because here in my country, most of the neurosurgical residents, they want to do spine. They are not interested in brain surgery. And, so I'm kind of having the opposite mentoring. So I'm trying always to mentoring them, to like brain surgery and keeping away from spine surgery. But I mean, this is a school of thoughts. And I think once you learn how to, and this was also my odyssey. I learned how to decompress very well when I was a resident. But we were always afraid of instrumentation, of putting screws. And I think once you learn the biomechanical principles and you are confident with the instrumentation of the spine, you start to learn and to solve spine cases and delicate spine cases. And I was trained in Glasgow, part of my training. And I was very fortunate to have a spine consultant, Robin Johnson, who taught me a lot about these biomechanical principles. And I was operating with them, and he would tell me, look at this C1, C2, high unstable situation. People talk about aneurysms, and they're very excited about aneurysms. But here we can ruin this patient if we are not proficient and we don't apply the screws and we don't solve the situation. So slowly, I start to understand that we have a major role on those cases and we can do a lot for those patients. And these are very thrilling situations and surgeries, and you can get a lot of rewarding for that. On the other hand, I don't think neurosurgeons doing spine should, at least in my generation, should quit neurosurgery. I still do a lot of neurosurgery, complex intracranial tumors, cranial base, intrinsic tumors. And I think this helps me a lot to have a 3D understanding, skills to properly end spine lesions. And it's completely different seeing an orthopedic surgeon operating a spine from a neuro guy. And we should not forget this technique and this respect for tissue handling, for anatomy layers, for 3D thinking. And the brain surgery gives us these skills, I guess.
Thank you. So maybe Endo Sensei, so you can make some comments how you can move to the Japanese young neurosurgeon towards to the spinal interest.
No, I mean lately the many Japanese neurosurgeons is more interested in spine surgeries, as far as I can say. When I was younger, the residents were not interested in spine surgery. The spine is orthopedic surgery part, mainly in Japan. But I think things are changing. So I feel right now relatively more optimistic about bringing the young neurosurgeons coming into the field in Japan. Would you like to make some comments, Salim?
It's a big problem for maybe all country, but I think we need to send the doctors to the center to focus just spine pathology for education. It is important. High volume centers. For that, all doctors can come back and they can change a lot of things. It is important, I think. The fellow program is.
Yeah.
Yeah,
Okay.
yeah,
Please.
yeah. So I agree with Dr. Oscar. In my country, most of the neurosurgeons do spine, and obviously they are also doing brain. The unique advantage which I believe as a neurosurgeon dealing with spine is the uh, very gentle tissue handling which we learn with brain surgery, and that's actually a major advantage. And many patients in my country also prefer to get operated on their spine by neurosurgeons, and that's a big advantage. Regarding training, obviously, we are such a ACNS, under the umbrella of ACNS. We are such a good group that we can help each other in reciprocal training, and that will help the younger generation. Uh, if we can organize this courses under the banner of ACNS, and then that may be useful to a lot of uh, a lot of surgeons everywhere in this region.
Yes.
Please, Innocence, please close.
Yeah, thank you very much. We would like to collaborate more to educate young fellows and, trying to have more neurosurgeons to be involved in the spine surgeries, because it's a very nice field and an interesting part. Patient feel very happy after this good surgery. So we have to do it more, and we have to ask the young generations, neurosurgeons, to involve in the field. Let's collaborate together.
Yeah.
Thank you very much for today. I enjoyed a lot.
Thank you so much.
Thank you very
Okay.
much.
Bye-bye.
Thank you.
Next time.
Thank you. Thank
Bye
you.
bye. See you next
Bye-bye.
time.
Thank you.
Bye
Bye-bye.
bye.
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 Thank you, Roger.